Burgess is not only a fellow physician, but he's also a fellow Texan and has long championed since being here the emphasis on getting healthcare right, not just focusing on moving a bunch of dollars around and on administrative processes, he just said, but on actually getting to better quality of care. And I do think there is some reason for optimism in this round of healthcare reform in that people really are talking about the shortcomings of the way that healthcare works in this country and the importance that policies focus on supporting better care at a lower cost. You all are probably familiar with a lot of the evidence on the overuse of many medical treatments, with Medicare costs varying by 50 or 100% more from area to area, the underuse of many treatments, particularly those oriented towards prevention and preventing the complications of chronic diseases or preventing those diseases in the first place, the misuse of medical technologies, gaps in evidence. We have a healthcare system that doesn't promote steps and support steps by healthcare providers and patients or consumers to get better care at a lower cost. So it's probably not surprising that we see all of these kinds of gaps. If a physician takes steps to reduce healthcare costs today, like keeping his patients well by using email reminders or hiring a nurse practitioner to help coordinate care for chronically ill beneficiaries, or getting electronic record systems so that he or she can get information from other sources of care to help get better treatments for each individual patient. All of those steps mean that you're going to get reimbursed less by Medicare and maybe by private payers who sometimes follow Medicare approaches as well. And that means that despite your best efforts, when you go to work every day, like Dr. Burgess was saying, if physicians go in, 99% of physicians in this country and all the health professionals in this country go into work thinking, how can I do a better job for my patients? How can I keep them healthier? How can I get their costs down? A lot of the steps that you'd like to take are just really hard, if not financially impossible, given that the healthcare policies we have in place don't support these kinds of steps to get the best care at the lowest cost for each patient. So hopefully, as part of the healthcare reform effort, that can change. And forums like this, similar efforts in the Senate through the bipartisan effort underway with the Senate Finance Committee are bringing some of these efforts to the fore. I want to highlight 4 points very quickly that I think are important to address if we really are going to have healthcare reform that reforms the way that healthcare works, that empowers providers, patients, consumers to get to better delivery of care. First is measurement, second is payment reform, third is benefit reform, the fourth is better evidence. As you heard from Dr. Burgess, a lot of efforts in healthcare focus on measuring what's easy and therefore paying for what's easy. It's relatively easy to measure how many times somebody goes to their doctor's office, how many lab tests they get. It's harder to measure the impact of care on a patient's outcome, but that's really what patients care about, their outcomes, their experience with care. And there are efforts underway in the public sector and private sector and some collaborations to do a better job of measuring what matters to patients. For example, for patients with diabetes, there are now some good markers of how well blood sugar is controlled over time, called hemoglobin A1C. And that's something that is perhaps more important to patients than just whether or not they went into the doctor's office and whether they got a certain lab test and how well is their diabetes being controlled. Also, we're making progress on patient experience measures so that there's consistent information available on how patients are experiencing care. And for people with chronic diseases, they or their caregivers, frankly, are probably the best source of information about what's working in the healthcare system. So getting consistent measures available that can help people and their providers make more informed choices about care is really important for moving away from a system that emphasizes volume and intensity, not quality and value. With better measures of care, that brings me to point number 2. It's possible to reform payments based on quality and cost or value. And here I want to really talk about moving in a different direction for accountability. What do we want our payment systems to be accountable for? Our group at Brookings has been working with the Dartmouth programs that have looked at area variations, and also with researchers around the country like John Goodman at the National Center for Policy Analysis on a different way of setting up provider payment that basically works as follows. If you can get better outcomes at a lower overall cost, you should get paid more for those steps, whatever they turn out to be. In the Medicare program, while I was director of the Centers for Medicare and Medicaid Services, we implemented a pilot program along these lines for some multi-specialty group practices. They continue to get paid according to the traditional fee-for-service system in Medicare, but in addition, they also started reporting on the outcomes and other important aspects of quality of care for their patients, how their population of patients was doing in terms of preventive care, how they were doing with controlling their diabetes, with managing their heart failure, with managing their coronary artery disease, and some of the other common conditions that make up most of Medicare expenditures. And Medicare also tracked the total spending for these patients in the program, not just on physician services, but everything, on hospitalizations for complications, on rehab, everything else. And the deal was that they could identify or they could document improvements in outcomes for their patients and reductions in overall cost trends. They got to keep most of the difference in savings. A bit of it went to taxpayers up to a threshold, but beyond that, it went to these physician groups. That means it's now feasible for these groups to implement steps like getting patients out of the doctor's office, reorganizing care so that it may not even depend on just on physicians, but on allied health professionals like nurse practitioners who can specialize in care for certain kinds of chronic diseases and do so at a lower cost and get better results for their patients, better measures of patient experience. At this point, about half of the group practices that are participating in this effort have reduced their spending trends by more than 2% per year. So that's even bigger than some of those numbers that you heard about last week with President Obama and some of the industry leaders. And all of them are showing significant improvements in outcomes. So better outcomes, lower costs. That's the direction that we need to go in. And this kind of movement towards payment systems that start to emphasize and hopefully increasingly emphasize better outcomes and a lower cost is an important step to get there. The Medicare Advantage program can help with this effort. Many private plans, I'm sure you'll hear from Lou and others, are also trying to move in the same direction. It's very important that we have both public and private sector efforts to put the emphasis where it should be on helping providers, supporting providers that are taking steps to get better outcomes at a lower cost. Third point I want to make is about benefit design. It's not just about providers, but actually I think a more powerful force in our healthcare system is consumers. Another program that I implemented while I was at CMS was the Medicare Part D program, the new prescription drug benefit. And this required a good deal of effort, a new kind of effort by beneficiaries in the Medicare program. When it started, there was a lot of frustration out there. I talked to a lot of the beneficiaries who had to spend some time comparing plans and looking at options. The government didn't just come up with a single benefit design that they had to take, and therefore they wouldn't have had to spend any time looking at different options. Instead, they did, and the result was that people overwhelmingly signed up for plans that were different in benefit design than the ones that Congress had implemented in the 2003 law. That had a traditional kind of benefit design where you had a deductible and 25% co-insurance and catastrophic coverage on the back end. Had that famous donut hole in between, but that was because Congress was working with some cost estimates that turned out to be 40%, 40, higher than the actual cost of implementing this program. The program cost turned out to be much lower, in good part because of the kinds of benefits that seniors chose and because of the changes in how they got their health care as a result. People overwhelmingly signed up for plans that had a tiered benefit design where generic drugs, which are just as safe and effective as the brand name when they're available, were basically free. They might cost $1 or $2. Preferred brand name drugs, drugs in the 12 or so categories of outpatient prescriptions that account for most outpatient prescription drug spending, cost $25 or $30 a month, so much lower than their regular costs. And most other drugs were covered, but people had to pay more of the cost at the margin. Actuarially, it's the same value or better as a traditional insurance design, but the difference is patients got to save more money when they met their drug needs at a lower cost. And that's what they did. There was a huge amount of shifting from branded generic use, went from 50 to 70% in the Medicare population. A huge amount of shifting from non-preferred to preferred brand name drugs. Drug costs in the program were much lower than expected as a result of these consumer-led efforts. There are similar steps underway to change benefit designs around other types of care, say bypass operations. Some bypass providers, for example, Geisinger Clinic, Mayo, now offering packages where they document that they're getting better outcomes, they document what the overall costs are, and they can work with insurers so that people who choose this kind of coverage can get the care at a lower out-of-pocket cost, even if they got a chronic disease, because they get to share in the savings more than they do in a traditional insurance plan. It's the kind of consumer-centric approach based on good information and benefit design that supports it. Finally, fourth point is better evidence on what works. There's been a lot of debate about so-called comparative effectiveness research lately. My hope is that comparative effectiveness research done right will promote the same kind of personalized medicine that I've been talking about. Can provide better evidence on, based on patient characteristics, genomic tests, other predictors of outcomes, what's going to work best for individual patients, and that, in turn, is not used directly for coverage decisions, in turn informs decisions that can lead to better decisions by providers, better decisions by patients on getting the best outcomes at the lowest overall cost. So, very glad that these steps are front and center in healthcare reform this year, and hopefully we can use this opportunity to really get to a high-value healthcare system.